I'm Mary Gay, Managing Director and Executive Lead for Quality and Performance for the CCG. But on the topic of stroke, I'm the SRO for the ICS for the Hereford and Worcestershire for stroke. And many, many years ago, it feels like now, I was a stroke ward sister as well. So I remember firsthand how difficult stroke services can be. There is a very defined national best practice stroke pathway based on many years of evidence that really stretches from preventing strokes, which is an important part of our work, and the work to prevent strokes in the first place. The once people have got a query stroke, as we call it, because it's difficult to diagnose until you get to a hospital. The pre-hospital pathway, what we should do pre-hospital to make sure largely that we identify these patients quickly and we get them to a hospital to a scan as quickly as possible, because that's the best outcomes for those patients. And then if they are diagnosed, sadly, with a stroke or what we call a transient ischemic attack, a mini stroke, as it's affectionately called, if they have a full stroke, it's that very important, recognised up to 72 hours care in a hyperacute stroke unit that they need to make sure they have the best chance of the outcomes, best outcomes for them as an individual and for their families that they can, and making sure that care is designed as per national best practice. And then the stepping down from that hyperacute care, depending on the outcome of that brief intervention. Where are they best placed to start their recovery? Is that in acute hospital carrying on their acute care? Or for a lot of patients, it's a lot better to get back to their own environment and have the proper rehabilitation support that they need to carry on their recovery. And lastly, the long-term care, which is often not something that is not focused on as much. The life after stroke is really important, both from a physical, but even more so from a psychological point of view, for that individual and their family to manage the long term. Says nationally, stroke workforce is a challenge. It's not just Hereford and Worcestershire. This is a national issue in workforce, and we have in recent years been relying heavily on very good locum doctors to come into our system. Unfortunately, there have been excellent doctors, but not being able to get that substantive workforce that we need to deliver 24/7 care in acute trusts that patients need. So we've not had any individuals that we can find that have directly resulted in harm as a result of that. But what we want to do is have a very sustainable service going forward. So going back a little bit, so we've done a lot of work on.
I'm sorry, Mary, we lost you for a bit. Yeah.
Sorry, I think somebody muted me then. Sorry. So we've done an awful lot of work on preventing strokes, which is largely with public health around healthy lifestyles. But with our general practice, we have worked to get them to understand to diagnose atrial fibrillation early, which is one of the indicators of the risks of stroke. And we have seen, comparing to other areas, a stabilisation of our stroke numbers, which is really pleasing to see. And we continue to do more work to prevent strokes going forward. The big issue for us has been the workforce, as I say. So we were in a position a couple of months ago, unfortunately, where we lost even more consultants. And we reached out to the region, who have been, I have to say, we have to put on record, have been fantastic in helping us to get other doctors from other hospitals to come as an interim to work in Worcestershire and to support us. And we are currently in the position, we've probably got the best stroke workforce that we've had for many years. And as a result, we haven't told the board yet, Simon, but we've now got more interest from substantive consultants from across the region than we've ever had, which is pleasing to see. We've also developed a workforce that gives us 2 nurse consultants that we put out to advert, and we're really pleased that we've had 2 very experienced nurse consultants apply for those roles. So, with everything, if everything goes to plan, we will have a more substantive workforce than we've ever had, which is we're delighted delighted with, really. But what we want to do is get them to get to a position with the workforce that we have that national best practice care pathway in place across the whole of Herefordshire and Worcestershire. So what will that mean for us? We have been working for a long time on the best practice pathway for stroke. We've had national leaders come in, stroke experts, everybody who's come and supported us. And we have an emerging vision of what that would mean for the future. Now, I want to make it very clear that it isn't agreed, determined. We have got to go and engage a lot more with the public, with interested stakeholders. We did do this in 2018, but we were halted for various reasons. When we went out to the public in 2018, there was some very interesting feedback from the public, which was, that they largely weren't averse to moving together. They wanted to be in the best place for the care. What their main issues was they wanted us to improve long-term support for stroke survivors. They wanted to make sure that access to services was for clinical need and not where the available capacity was, which is really helpful. Better support for carers of stroke survivors, which I think is really important again. Better communication between stroke services and patients, particularly after the stroke and in that period of ongoing care. Greater emotional and personal support for those stroke survivors, and ensuring people who were younger who had stroke had services better tailored to their needs. There was a feeling from the public they were more tailored to the older age group. Our vision for stroke services for the future, and it is just a vision at the moment, is that the hyperacute part of the pathway, which I talked about earlier, that very acute focus, diagnostic, the 24, 48 hours, up to 72 hours care that's needed 24/7 by a stroke consultant team. We will have one centre in Hereford and Worcestershire to deliver that. And as soon as that patient is able to leave hospital, will be repatriated to their local area for their ongoing rehabilitation and support. We will have telemedicine, which is, connect a bit like we're doing now. Telemedicine, we're doing it on Zoom, but using medicine to support it between all to support the oversight by consultants across the whole system. And we will strengthen that pre-hospital pathway with the ambulance service to have better pre-alerts into the hospital to make sure that that patient who could have a stroke gets access to the scan that they need rapidly, and they don't enter an ED department. They will have a separate entrance to make sure they get that stroke service. Now, this has happened in various places across the country, and the outcomes speak for themselves, the speed of the pathway, the workforce improvements, and the national leaders are encouraging all areas to look at this. In fact, Wolverhampton Walsall did this not long ago, and they've seen definite improvement in their outcomes. So we're at the stage that in January, we're planning to go through, take all the clinicians away for a good afternoon, go through the pathway step by step, make sure everybody's comfortable. And then we want to work alongside Health Watch, the Stroke Association, the region, to again begin that public engagement and understanding of what we're proposing and influencing from the public point of view. And then we'll hopefully take this through the clinical senate and put it in as a model in probably 1 to 2 years. So our focus at the moment is maintaining the services we've got with workforce. And as I've just said, we're in the best position we have been for probably 2 to 3 years at the moment. We want to sustain that. And hopefully that will improve our performance. But we are planning for the future to make it as, to give us that robust 24/7 model that we need. We have escalated this regionally and nationally, as have other areas, that the workforce planning for stroke consultants nationally needs to improve, because we are concerned that we are really not, the workforce is not fit for the future at the moment. So that's where we are with stroke. Better position than we were probably 2 months ago. Still fragile, and we need to keep a very close eye on it, which we do. But we have that vision for the future that we are working together. So Herefordshire, Wye Valley Trust and Worcester Acute are working together more to make sure that when we're recruiting any staff, we're doing it jointly to prepare us for the future. That's a very quick tour through what is a very, very complicated pathway, but happy to take any questions and discussions, Joe, if that's okay.
Thanks very much, Mary. Do I have any questions from the board? Simon.
Just before we start the questions, can I just, with Mary, just bottom out what happens to somebody if one must attend them and think they've got a stroke, in terms of, you know, they're taken, and if we focus on Worcestershire, I appreciate James here and you're here for the system, Mary, but if we can just focus on Worcestershire, they'd be taken to one or either of the A&E departments in the county. Could you take us through what would happen? Because that's where the big bit of people, we have difficulty telling people what should have happened to them in their circumstances. Yeah.
So what should happen is that if a patient is query a stroke, because I think it's very hard until you actually have sight of the patient and can get some investigations done. The pathway currently is to the Worcester Acute site, not to the Alex site. Now, there will be the odd patient that displays unusual symptoms that don't even look like a stroke, that will get to the Alex and will have to be transferred quite quickly to the Worcester Royal Hospital. But that happens very, very rarely. The reason it's Worcester is because that's where we currently have what we call HWW, the hyperacute stroke unit, with the stroke consultants and the workforce and the scans there to do it. So they'll attend Worcester Acute. There should be a pre-alert from the ambulance to the hospital to say, we've got a patient with stroke. They currently go through the ED department. And as you know, our ED department, like every ED department in the country at the moment, is very, very full. But they do take priority, these patients. They're called category 2. They do take priority. And they should be taken through the ED department quite rapidly with an assessment at the front door to get to a scan and determine, yes, they have had a stroke. If they have had a stroke, they go straight to the hyperacute stroke unit for the consultant care, accompanied by the stroke specialist nurse who will come down to ED to collect them. If they haven't had a stroke, they stay in the ED department to find out, have other investigations. If it's believed it's a transient ischemic attack, which is, you know, a short period of symptoms and then resolving, there is a pathway in to have an appointment, usually within 24 hours, to see a consultant to see what, you know, to understand what's happening, which is slightly different to that. We quickly think they've had a stroke and they're not recovering very quickly. If they've had the scan and it is a stroke, there's 2 routes. If they believe it's a stroke caused by a clot, they can have what we call thrombolysis, which is a drug that dissolves the clot and hopefully resolves the symptoms. If it's a stroke that's caused by a bleed, then it's more intensive care that's needed on the hyperacute stroke unit to make sure that they are recovering and getting the active rehabilitation they need as quickly as possible. And that's the route we go that happens.
Are there any timescales attached to this in terms of targets that we see published, just so that people understand that?
So it's the golden hour, as we call it. So with it, you know, the patient, I mean, once the patient's been picked up by the ambulance and through the system, it's the hour to get to the scan and any treatment, particularly thrombolysis, that is important if it's a thrombolytic stroke.
Right. So that's
sadly, a lot of patients, this happens in the night, so it's only when they wake up in the morning they realise they've got a problem, and obviously this could have happened in the night any time.
Yeah, so that's an hour to the scanner from arrival at hospital, is it?
No, it should be from the ambulance.
From the ambulance attendants. Yeah.
From the ambulance leaving the patient's house.
Right. Okay. So that's an hour to the scanner, and then the thrombolysis should take place within, if they're suitable for thrombolysis. And I take what you say about the timeline having to be taken into account. because people might wake up presumably with the symptoms of a stroke and they don't know when they had it in the night. So what's the timelines for that part of the pathway?
Well, it depends. It's an individual patient point of view. So if they've woken up with symptoms, they'll come in, and the scan will show. You can tell from the scanning sometimes how long ago this happened, or roughly how long ago this happened. But and they'll look. It's not just the scan; it's the physical examination, etc. That's all part of it. But the overall rule is if they are suitable for thrombolysis, because not everybody is, they will do it. They aim to do it within the hour from leaving and getting that thrombolysis. But remember, we only thrombolyze roughly 10% of patients. It's very small numbers.
Yeah, I understand that. And then the other question I wanted to ask you is about the data that's reported on. And the reason I want to ask you that is I'm doing a piece of work for the West Midlands Local Health Watch, and I've been looking across other hospitals, and they don't seem to publish the same data sets across the Midlands that our acute trust publishes. In fact, I've got to say, in fairness to our acute trust, they seem to be very transparent with the data that they publish. But is there a standard set of data outside the meeting? You could perhaps confirm for me the standard set of data sets, and that would be really helpful. And then finally, just before I hand over, we had a signposting yesterday. Susie, can you just run through that signposting for Mary? Just raise that issue that was raised with us about stroke clinics.
Yeah, sure.
Because where do they fit into the stuff?
Yeah, so we had a call from a lady yesterday morning who had been diagnosed as having had a stroke, I think about a month ago, and she was referred to her GP, and her GP referred her to the stroke clinic at Worcester. She received a letter confirming she was waiting, on the waiting list for an appointment, but hadn't heard anything. So she rang the day before yesterday. She rang the clinic, and they said that unfortunately there wasn't a clinic running at the moment because they hadn't got the staff. So she rang us because she was really concerned to hear that, and wanted really some clarity on what was happening there and when she might be able to have an appointment.
Okay, right. I will deal with that urgently after this call. I'll make sure that's resolved. Okay.
Thank you.
Simon or Susie, I'll speak to Paul Brennan and I'll come back to you. Okay.
Great. Thanks.
Thanks very much, Mary. I can see we've got a question from Martin.
Yeah, I've got two very brief ones, actually, Joe. I just wanted to know if the future plans implied enhanced training for paramedics. And I was also wondering what better support for carers would look like.
Okay, thank you. I'll deal with the paramedics first. I mean, as I always say, our paramedics are the best trained clinicians. I think across the field sometimes they are brilliantly trained. But what we're aiming to do is try and get some telemedicine links between the paramedic ambulance van and the acute consultants as well at the same time. So they've got that support. They are very good now at identifying the signs of stroke, heart attack, brain bleed. They are excellent at that. But what we want to do is enhance that and give them some more access directly to a stroke consultant, and we can do that by telemedicine if we can get that sorted. I mean, one of the the 5G will help us because some of our areas are very remote and the internet's not great. So we're hoping that the continued improvement of the internet will help us to get that telemedicine in place. So that is our plan for the future. Okay, what better support will look like for stroke survivors? That we want to co-design that with patient groups and carer groups. A lot of it seems to stem from the need for better communication and psychological support. Those seem to be the two issues. but we want to co-design that definitely with the public and patients and ex-patients with stroke.
Thanks, Mary. Jane.
Hello, Mary. It's a follow-up really from Simon's question. You said that obviously services have improved over the last 2 months, but I wondered what are the outcomes for patients in Worcestershire at the moment and how we both compare regionally and nationally. Thank you.
I think it's breaking off a little bit. I think I got most of that. It was things have improved from a we've got more staff on the ground, which is, you know, consultants particularly, which is great to see. And as you know, you'll see next week at the stroke board, we've got our new dashboard that will show us over the last few months the outcomes that you know, that from our best practice pathway. So we're now monitoring that much more closely. And as I say, we haven't seen a deterioration, but we haven't seen an improvement on the outcomes that we've been monitoring for the past couple of years. So, but we'll look at that more closely next week. Despite everything we've been through, we are not benchmarking lower than anywhere else in the region at the moment. The only thing I would say is the time spent on a stroke ward rather than a general ward is not where I'd want it to be. We want those patients to those stroke wards as quickly as possible. That is largely down to the pressures in the ED department in Worcestershire. And the reason for the new model where the patients won't go through an ED department, they'll go through a specialist stroke centre, for want of a better word, for emergency care. They will go straight through and straight to scan. So the reason we want to get to that position is A, to sustain it long term, but B, that patients will get quicker access to it. So that's the one area that, you know, we've been focusing on in the group.
Right, thank you.
Okay. Does any other directors or co-opted board members have a question for Mary? Okay, I've got a couple of questions from the public. So, Brendan.